Now we're going to talk about folate deficiency and vitamin B12 deficiency. So remember, this would be megaloblastic anemia. The difference between megaloblastic and macrocytic anemia is that macrocytic anemia has mean corpuscular volume greater than 100 femtoliters, and a megaloblastic anemia is this plus segmented neutrophils. The segmentation of neutrophils would be that the average mean of lobules in a neutrophil is more than 4 lobes, or that more than 5% of the cells have more than 5 lobes. This would be a hypersegmented cell. And the red blood cells would have a macroovalocyte appearance. First, the macrocytosis means that it is larger than a lymphocyte, but the macroovalocyte means that it is not just a sphere, it is with oval shape, and this would only be seen in the megaloblastic anemia. In other videos, we talk about other causes of non-megaloblastic anemia, that is the macrocytic anemia, for example, diamond black fan anemia, or other diseases like liver failure or alcohol intake. Alcohol intake sometimes can lead to megaloblastic anemia, but we will touch this later. Alright, so megaloblastic anemia could be due to decreased vitamin B12, so vitamin B12 deficiency, or folate deficiency. First, for folate deficiency, would be decreased intake in the green vegetables that contain folate, or because increased demand, for example, in pregnancy or cancer patients, or in anemia. Many anemias can have also folate deficiency. For example, patients with sickle cell disease need replacement with folate, so that patient with sickle cell disease can develop a megaloblastic anemia due to folate deficiency. And also, the alcohol inhibits the absorption of folate as follows. Folate is found in food as polyglutamate. The enzyme in the small intestinal conjugase converts polyglutamate to monoglutamate, and then this is absorbed in the jejunum. Then, if alcohol intake is massive, then the alcohol is going to inhibit the intestinal conjugase, and so there will be at the end no absorption of folate, and so for that the patient can develop folate deficiency anemia. Now, the B12 deficiency could be decreased intake of vitamin B12, but also decreased absorption, or let's say bacterial overgrowth that is taking the vitamin B12. We will touch this a little bit more in the diagnosis. Vitamin B12 and folate deficiency present kind of the same, but vitamin B12 also have neurological symptoms. This is because in the beta oxidation of odd chain fatty acids, we have the fatty acid at the end of multiple beta oxidations. Here is just 3 carbons. So from this, we see this in the previous video, we pass to propionyl CoA by the enzyme propionyl CoA carboxylase is going to be converted to methylmalonyl CoA, and methylmalonyl CoA, let me put here methylmalonyl CoA, is then converted to succinyl CoA by the enzyme methylmalonic acid mutase. This mutase needs vitamin B12 as a cofactor, so if we don't have this vitamin B12, there would be no production of succinyl CoA and increase in methylmalonyl CoA. Now, methylmalonyl CoA goes into myelin and interferes with the myelin, so there will be neurological problems due to problems in myelination. This would present as subacute combined degeneration. The tracts that are mainly affected are the lateral corticospinal tract, the dorsal columns that would lead to decreased proprioception and fine tactile. They would present as positive Remark sign, and spinocerebellar tract. Both could present with any neurological symptom, including headache and memory or mental status changes, psychosis, etc. So in that case, there would be also helpful if we do a CT scan due to the memory loss and mental status changes. Now, the difference between B12 and folate would be one, the neurological symptoms, and another, the increase in methylmalonic acid that we would see in vitamin B12 deficiency. Now, patients with decrease in vitamin B12 or folate can have an increased risk of thrombosis, because remember that we need folate and vitamin B12 to convert homocysteine again to methionine. And if there is no conversion to methionine, there is increase in homocysteine, and homocysteine damages the endothelium and is disrupting the triad, the Bischoff triad of thrombosis. Alright, so differences, neurological symptoms, and methylmalonic acid increase. Sometimes if we give folate deficiency to a patient that has decreased vitamin B12, we will sometimes improve the hematological problem, but the neurological problem is going to get worse. When we give vitamin B12, the first that increase or that improve will be the reticulocyte count. In 2 to 5 days, we'll see the increase. And the last to improve, if it can be improved, would be the neurological symptoms. Now, vitamin B12 deficiency takes a lot of time to develop, 3 to 6 years. So it is very rarely that we have vitamin B12 deficiency. Vitamin B12 deficiency could be because decreased absorption, for example, in Crohn's disease, that the ileum is mainly affected, then vitamin B12 cannot be absorbed, or in Pernicious anemia. In Pernicious anemia is the most common cause of vitamin B12 deficiency, and it is due to antibodies against intrinsic factor and parietal cells. The decrease in intrinsic factor due to the antibodies makes that the vitamin B12 cannot be absorbed. And other causes include infection with the parasite, the Phyllobothrium lactum, that mechanically obstructs the ileum and so we cannot absorb the vitamin B12, and pancreatic insufficiency, because when we intake vitamin B12, then it is first bound to a protein-derived, animal-derived protein. Then with the saliva, we destroy this junction and we bind the vitamin B12 to a R protein. Then this goes into the stomach and the pancreatic enzymes destroys this link, and now vitamin B12 is free, and when binds to intrinsic factor, it can be absorbed in the urine. So we need the pancreatic enzyme to destroy the junction of vitamin B12 and the R protein. So we don't have the pancreas, or if there is a pancreatic insufficiency, there would be vitamin B12 deficiency. Now, the labs would see a decrease in reticulocyte count because we don't have the ingredients to produce the red blood cells, the reticulocytes, that we will have decrease in folate and vitamin B12, because remember that we need folate in order to DNA synthesis, because we need to pass from uridine monophosphate to thymine monophosphate by the enzyme thymidine synthase. And this is accomplished by methyl tetrahydrofolate. Is the folate plus a methyl group. This methyl group is going to pass from the uridine monophosphate to the thymidine monophosphate. So we will see decrease in reticulocyte count. That when we replenish the patient with vitamin B12, we will see this increase in 2 to 5 days. Next, there is ineffective electrophoresis, because even though the reticulocyte is decreased because of production, also the red blood cells are not being produced or going out of the medulla because there is decrease in reticulocyte count. There is no destruction of red blood cells, but there is ineffective erythropoiesis because we cannot produce the red blood cells because we don't have the correct ingredients. So even though the bone marrow be hypercellular, the reticulocyte count would be decreased. Now, the best initial test for the diagnosis of vitamin B12 is measuring vitamin B12. If we continue to suspect vitamin B12 deficiency and the values of the levels of vitamin B12 are normal, next step is to look to methylmalonyl-CoA levels. And if it is increased, then the diagnosis of vitamin B12 is done. Sometimes vitamin B12 could be increased or normal in vitamin B12 deficiency because this anemia, as any anemia, or in other situations of stress, can increase the vitamin B12 levels. So the patient would be stressed and we would not see the decrease in vitamin B12. Now, for the diagnosis of etiology of vitamin B12 deficiency, we take the values of antibodies against intrinsic factor and parietal cells, and if we see this, the cause was pernicious anemia. And remember that it's associated with other autoimmune diseases like Addison disease, Hashimoto's thyroiditis, etc. Now, for further evaluation of vitamin B12, if we don't find the antibodies, we will do the Schilling test. This will begin to give vitamin B12 intramuscular and radio-labeled oral. The intramuscular is in order to replenish all the organs of the body with vitamin B12. And the radio-labeled is that once we have replenished the body with vitamin B12, then the radio-labeled would only be dropped in the urine because there is no need more of the vitamin B12, so they would drop out in the urine, and we would see it because it is radio-labeled. So we would see the hormones that are radio-labeled. So if the patient had a decreased intake of vitamin B12, we would see the increase in vitamin B12, radio-labeled vitamin B12 in the urine. But if it is low, that means that the problem wasn't the intake. So next step, what if the problem is a decrease in absorption due to a decrease in intrinsic factor? So we give intrinsic factor. If we see an increase in the vitamin B12 in the urine, so the cause was pernicious anemia. If we see a decrease, that means that the problem wasn't the pernicious anemia, and so we go further to give antibiotics because the patient would have a overgrowth of bacteria and the bacteria is taking vitamin B12, and for that the patient has vitamin B12 deficiency. So if we see now an increase in vitamin B12 after giving antibiotics, this was intestinal bacterial overgrowth. If we continue to see decreased vitamin B12, that is, we don't see vitamin B12, then we give pancreatic enzymes. And if we see an increase, then the patient has vitamin B12 deficiency due to pancreatic insufficiency. And if it is decreased, we need to consider other causes like gastric resection or things like that. Remember that patients with gastric resection can develop vitamin B12 deficiency, but only like 3 to 6 years. So in any case, we need to consider those things. So the most important is, for example, differentiate between the vitamin B12 deficiency due to intake and the other causes, because when we give vitamin B12, radio-labeled vitamin B12, we would see it in the urine if it was vitamin B12 deficiency due to decreased intake, and in any other of the causes, we would not see it in the urine with the first trial, and the first trial is giving the radio-labeled vitamin B12. Alright. But this Schilling test is rarely done. It's just done when we don't find the intrinsic factor antibodies. Now, these patients with megaloblastic anemia can present sometimes with a normocytic anemia if there is a mixed microcytic and macrocytic anemia. That is, let's say that the patient has sickle cell disease and develops folate deficiency, but also iron deficiency. So if there is folate deficiency and iron deficiency, folate deficiency, macrocytic anemia. Specifically megaloblastic, what is a macrocytic anemia? And iron deficiency anemia is microcytic anemia, so the mean corpuscular volume would be normal, and we would see a normocytic anemia.